Welcome back to Dr. MedEd, your trusted source for high-yield medical education. Today, we're diving into a challenging yet crucial topic in cardiology, cardiac sarcoidosis diagnostic criteria based on the 2014 HRS guidelines. Let's get started. Definite cardiac sarcoidosis. When can we call it definite cardiac sarcoidosis? Only when endomyocardial biopsy reveals non-caseating granulomas, and we've ruled out other culprits, like tuberculosis or fungal infections. Although this is pathognomonic, remember, the biopsy is rarely positive because of low sensitivity and sampling errors. Probable cardiac sarcoidosis. If a patient already has histologically confirmed extracardiac sarcoidosis, say in the lungs, lymph nodes, or skin, then we consider probable cardiac involvement if just one of the following is present, and other causes are excluded. Steroid-responsive cardiomyopathy or heart block, LVEF 40% without another known cause, unexplained sustained VT, Mobitz 2 or complete heart block, late gadolinium enhancement on cardiac MRI, multimodality imaging, combining FDG PET and cardiac MRI, forms the backbone of diagnosis when biopsy results are negative, whether for cardiac or extracardiac tissue. FDG PET detects active inflammation, while cardiac MRI highlights fibrosis or scarring, giving us a comprehensive picture of disease activity and progression. Our diagnostic journey starts with clinical suspicion. Be alert for red flags like AV blocks, ventricular arrhythmias, recurrent syncope, heart failure, especially with a history of systemic sarcoidosis. Next, confirm extracardiac disease. Biopsies from lung, skin, or lymph nodes are safer and more sensitive than going after the heart. Slide approach step 3 and 4. Now it's time for imaging. Cardiac MRI looks for late gadolinium enhancement, especially in a patchy subepicardial pattern. FDG PET spots inflammation. We're looking for focal uptake. Some centers even use hybrid PET MRI or PET CT for more precision. And finally, rule out ischemic causes. Use coronary angiography or CT angiogram if needed. Let's summarize the diagnostic certainty levels for cardiac sarcoidosis. Definite cardiac sarcoidosis. This is diagnosed when there is a positive myocardial biopsy showing non-caseating granulomas in the heart tissue. It's rare, but definitive. Probable cardiac sarcoidosis. Here, there's a biopsy-proven extracardiac sarcoidosis combined with cardiac imaging findings or clinical criteria like AV block or VT. This is the most common pathway to diagnosis in practice. Possible cardiac sarcoidosis. This level applies when no biopsy is available or positive, but there is a strong clinical picture, suggestive imaging, and other causes have been ruled out. It's a diagnosis of exclusion, often made in high-risk or symptomatic patients. Always remember, clinical judgment and multidisciplinary collaboration are key when histologic proof is lacking. Let's wrap it up with the key learning points. Cardiac sarcoidosis worsens prognosis. Screen all sarcoidosis patients for cardiac symptoms. PET shows inflammation. MRI shows scarring. Steroids are first line, but immunosuppressants may be needed. Consider an ICD for low LVEF, ventricular tachycardia, or other high-risk signs. Thanks for watching. If you found this video helpful, don't forget to like, subscribe, and share with your fellow med learners.